FGR. And this webinar has been initiated by Dr. Asha Jain, who is a Medical Director of Cancer Prevention Relief Society, in association with Madurai, Ludhiana, Jamshedpur, Mathura, and Bhimavaram Obs and Gynae Society. Along with it, also Society of Fetal Medicine Chhattisgarh is associated with this webinar. So first of all, it's my pleasure to welcome our convener, Dr. Sujayashree Sangeeta. And Madam is a founder secretary of Bhimavaram Obs and Gynae Society. And currently she is practicing as a Obs and laparoscopic surgeon at Sheshadri Hospital. And Madam got so many awards and having the interest in laparoscopy and infertility. And Madam has done so many poster presentations in various conferences. And currently, Madam is conducting awareness program Vikasam for the adolescent girl. So over to you, Madam.
Thank you for that kind introduction, Mr. Mehul. So proceeding forward, I would firstly like to introduce the program director, Dr. Asha Jain ma'am, who actually requires no introduction. But moving forward, she's the director of SMSA Hospital Raipur. She's also the medical director of CPRS NGO, elected member of CG Medical Council, zonal chair Foxy Food Drug and MSC Committee, West Zone. She's the chairman of Mission Pink Health, IMA Raipur, executive member of ISCCP, your CG ISAR, and also CG SFM. The previous posts held by her are she has been the president of Raipur OB-GYN Society, vice president of IMA Chhattisgarh, president Rotary Club of Raipur North. She has received training in colposcopy. She is a certified instructor in FCCS OB course. She has received IOTA certification. She also received certification in gynec ultrasound, fetal medicine. And her fields of interest are saving the uterus, fetal medicine, OB-GYN ultrasound, critical care, preventive oncology. Currently, she is the trainer of ISCCP colposcopy. So, welcome, ma'am, to today's program, and I request you to please take it forward.
Thank you so much, Dr. Sujayashree. So, Mehulji, if we could pray to the divine first before we officially go ahead with the program. So, I would invite everyone to join in the Ishwar Stuti and Ganesh Vandana and Deep Prajwalan.
Network issue?
Namaskar, all respected dignitaries, to this 22nd edition of Searchlight series of webinars. I want to welcome Madurai, Ludhiana, Jamshedpur, Mathura, Bhimavaram societies and the Society of Fetal Medicine Chhattisgarh that has kindly agreed to join with me in this webinar. I also want to thank all of Society of Fetal Medicine that has been supporting me through this endeavor by giving me star speakers and joining in for topics and looking at them from the gynecologist perspective. So thank you so much. And we have the president, Dr. Shah sir, who is actually the president of Society of Fetal Medicine, and he will be speaking to us about early FGR today. I welcome Dr. Gokul Chandra Das sir, Dr. Deepak Bhagre sir, Dr. Manju Shukla ma'am, who have agreed to spare their precious time to join us. I also welcome Dr. Ginni Gupta, Dr. Mahalakshmi ma'am, and Dr. Bhavna Sharma, who are joining us as chairpersons. Dr. Mohit Shah sir, the speaker for the evening. I welcome our expert, Dr. Harshad Ruprela, the president of Chhattisgarh SFM. I welcome Dr. Manu Singla, Secretary, Ludhiana Society, Dr. Padma S., Secretary, Madurai Society, Dr. Samira from Hyderabad, Dr. Alokananda Rai from Jamshedpur, Dr. Tushar Ranjan Meher, an executive from Chhattisgarh SFM, and Dr. Anu Goel, Secretary of Mathura. I welcome everyone to this webinar. We usually don't keep the pleasantries too long because everybody is sincerely waiting for the academic exchange. I would like to ask Sujayshri, would you please introduce Bhagde sir and take the program forward? Dr. Das is calling me, so I will call him and organize his joining.
Yeah, so introducing the guest of honor, we have Dr. Deepak Bhagde sir with us and Dr. Manju Shukla. Firstly, introducing Dr. Deepak Bhagde. Sir has been the past president of SOGOG, All Gujarat Gynac and OB-GYN Society. He has passed his master's and DGO with gold medal from Ahmedabad in the year of 1981. The past positions held by Sir have been, he's been the head of department at MP Shah Medical College, Jamnagar. He's received the first ever SOGOG oration in 2014. And he has also delivered about 63,000 babies in private practice since the year 1985. So it's a very great honor of us to have you with us today. Moving forward to the next guest, we have Dr. Manju Shukla with us. Madam is the retired professor of OB-GYN, KGMU Lucknow. She's also the retired professor and HOD OB-GYN, CIMSH Lucknow. She's the president of UPCOG, president of Lucknow OB-GYN Society. She has also been the chief editor, Journal of UPCOG. She's the president, Association of Private Gynecologists in Lucknow, master trainer, contraceptive technology. She has also been the master trainer in maternal health. She's trained many people. So Madam has been the president of numerous societies. So it's great privilege for us to have you with us today, ma'am. So I welcome both of you to today's session. We would like a few words of wisdom from you, ma'am. And sir.
Dr. Deepak kahan hai?
Ma'am, please say a few words, ma'am. We'll see if sir joins in.
Sir has joined already.
No, that's fine. Dr. Manju, please carry on.
No, you carry on first.
Oh no, I
So
got a
Dr. Deepak,
professor. No, let it be Manju first because
Or should
she's a
I?
good. Yeah.
ma'am,
Anyway.
let's have the ladies go first, ma'am. If you can
Yeah.
say a few words, then we'll have Dr. Deepak, sir, also put in a few words.
Okay. Thank you, Asha, for inviting me in this learned gathering. Speak few words is very difficult. First, you have chosen a very good topic, FGR, which is still very difficult to understand, multifactorial disorder, and very difficult to treat actually, because you cannot reverse this FGR, and it is very bad. It has very bad effect on fetus. So let's hear the learned people about FGR. I think panel will be very interesting, and congratulations for conducting this 22nd Searchlight program, and congratulations, Asha. And I Dr. Deepak, go ahead.
Yeah. Thank you, Dr. Sujashri. Thank you very much for the kind words. Dr. Asha, I don't know
Yes, yes.
how you, Dr. Asha, I've been knowing her since last decade. Dr. Manju, since years before, also we have been meeting. And has become a great, great platform to get us all together. Corona, we of course dread, but one positive point probably is this web series which have started. But personally, I feel it has been really mushrooming, and I really don't know how you manage so many web series every day in and out. But anyway, it is surely imparting a great, great, great knowledge to us, all of us. Asha, what do I say about you? Your patience, your knowledge, and working for Foxy. Since I know you, you've always been like this, doing something for someone, and your passion has always been Foxy first. So, yes, your endeavor to stand for a post and serve in, as I said, a very big name committee, food, drugs, medical, surgical equipment, and we are sure all of us here and everywhere in India who love you, and I'm sure you will have all the chance to serve Foxy and all of us. I wish you all the best in that. And yes, the program itself is great. And as rightly said, etiology, we don't know in many of the things and what you are going to do. But of course, the diagnosis has made the life easy. The perinatology, the NICU has made a lot of difference since we passed out in earlier days. Thank you very much again, Dr. Asha. All the best, and wishing all the best to the web coming in. Thank you. Thank you, Sujesh, also.
Thank you, sir. Thank you, Dr. Yeah. Please, ma'am, go ahead.
Thank you, Manju ma'am. Thank you, Bhagde sir. Thank you all those for those wishes. I really need them. And I think I have fallen in love with my own series. We work on it. We take good topics, and imparting knowledge has become sort of a passion. So irrespective of election, I think this is going to go on. Hopefully, if everybody agrees to participate. And, you know, Dr. Gokul sir has joined in, and I will say a few words about Mohit Shah sir once he's been introduced. So, Dr. Gokul Chandra Das sir is OSD Srimanta Shankardev University of Health Sciences, Guwahati, founder, professor, and head Gynae Department, TRIMHS, Naharlagun, Arunachal Pradesh, professor and head Department of Gynae, Guwahati Medical College, 2012 to 15. Officer in charge, Fields Units, Guwahati, VP, Foxy 2014, member governing body, ICOG, President Guwahati Society, President Association of Gynec Societies of Assam and Northeast. He's delivered multiple lectures, published papers, published articles, and he's traveling from Shillong to Guwahati. He's driving himself, and he has kindly agreed to say a few words to us. So welcome, sir. Welcome to this forum, and we await your blessings.
Thank you. Thank you. I'm audible.
You are audible, and a big, big hello to you, sir.
दीपक जी नमस्ते.
Very good evening,
हमेशा अच्छा
sir.
लगता है आपको देखने से. हमेशा अच्छा लगता है.
नहीं,
मुझे भी
it is-
जवानी आ जाते हैं आप सबको देखने से.
It is all the blessings, for you've been a great, great friend since last almost 25 years, and yes, we have gone along.
आशा जी तो काफी कम कर रहे हैं, क्या बताएं. She has been doing so great well.
I know.
I don't
But
have words to express my thanks to her for inviting me to this seminar. And she has really picked up a very important topic, and everybody has said about the importance of the topic and relevance of the topic. And I'm sure we will be enlightened by the galaxy of speakers. And we wish Asha ji all the best. And we really wish that she continues with her great work. And here is wishing all the best from myself and from the rest of the Assam and the Northeast societies. Thank you, Asha ji. Thanks a lot.
Thank you so much, sir. Thank you for logging in while you were traveling. Thank you so much. So with this, we end our inaugural ceremony. I thank all our guests, Manju ma'am, Deepak sir, and Gokul sir, for joining us. And we will now proceed with the academic session. Inviting Sujya, would you please introduce our chairperson?
Yes, ma'am. So the session is guidelines for diagnosis and management of early FGR. So we have three chairpersons with us. Firstly, we have Dr. Ginny Gupta. Madam has done her MD and FICOG. She's from an ex-member of JIPMA, Chandigarh. She has completed her post-graduation 24 years back. She's a chief consultant at Healthline Hospital, Ludhiana. She's also the president of Ludhiana OB-GYN Society. She is a member of SFM, SMC, and AIWF. Manyata champion and coordinator of Punjab. She has special interest in safe motherhood, adolescent gynecology, and high-risk pregnancy. She has also been a faculty at various state and national level conferences. The second chairperson for today is Dr. Mahalakshmi. She is presently the professor of OBG department at Madurai College. She has passed out and she's completed her MBBS from Madurai Medical College in the year 1990. She has also done her master's from the same college in the year 2001. She is the secretary of Madurai OB-GYN Society during the year of 2017 and 18. She has completed 27 years of government service, and she has also been a teacher for both undergraduate and postgraduates. She has worked as a professor in Tirunelveli and Teni Medical College. She is a district emergency obstetric care trainer for many batches. She has also been in the organizing team for many conferences. She has presented papers and posters in various state and national conferences. Welcome, ma'am, to today's session. Next, we have Dr. Bhavna Sharma. She is the president of Mathura OB-GYN Society. Welcome, ma'am. I request Dr. Mahalakshmi to please say a few words, introducing our speaker for today, Dr. Mohit V. Shah. Dr. Mahalakshmi, ma'am, are you with us?
Good evening, all. It is very fine to join in this panel discussion. And I thank Asha madam and I wish her for the Food and Drug Committee elections. We thank all the chairpersons and the panelists who have joined here to talk about difficult topic, which is a difficult topic really, early FGR. Next to Dr. Mohit Shah. He is the National President of the Society of Fetal Medicine. Sir is the National President of Musculoskeletal Ultrasound, and he is the Vice President of the Indian Federation of Ultrasound and a Consultant Fetal Medicine at Surya Mother and Child Center. The postgraduate diploma is from MSK Scan from University of Organizing Secretary for the FETOCON in 2018, 19, and 2022. Welcome you, sir, Dr. Mohit, sir, and welcome you all.
I would like to add a couple of words about sir while sir continues to share his screen. I asked him to join in and he has just agreed. Means I was shocked. All the great people of SFM, they are ready to support in 1 minute. Dr. Ginny Gupta has joined us. Dr. Ginny, would you like to say a few words?
Thank you, Dr. Asha. It's amazing to be a part of this great webinar, and I thank you and congratulate you for joining, organizing this with such an esteemed faculty. And Dr. Shah, I cannot stop talking about him. It is a delight to listen to his lectures, and sometimes we feel that we should record his words. And this is a topic which is not well written in books or we don't have much literature. And this are the early IUGR is the one where most of the obstetricians are faltering in how to manage. So it's a great pleasure today and welcome, Dr. Shah.
Thank you for your kind words, Dr. Giri. Nice to see you. I see you're traveling.
Yes, sir.
Okay. So good evening, everyone. To all my seniors, Dr. Deepak Bhai, Dr. Gokul, Dr. Manju, all my chairpersons, Dr. Gini, Dr. Mahalakshmi. I would like to, thank Dr. Asha Jain for allowing me to actually cut this down to and restrict myself to early growth restriction, because you have to understand when we talk about FGR, there is an understanding now that things do not resonate with the terms like symmetric or asymmetric anymore. You have to understand that we now understand pathophysiology much better. We understand the clinical picture probably fairly better, but most importantly, Doppler has made a tremendous influence in understanding, predicting, and monitoring growth restriction. So when we talk about fetal growth, that is one of the key objectives of prenatal care. Every obstetrician in every follow-up scan takes the fundal height simply to see whether the fetus is growing well. And you have to understand that fetal growth depends on a lot of factors. The most important here being the uteroplacental function. Of course, you can have maternal diseases, you can have a maternal cardiovascular function, a cardiac disease can hamper growth. Maternal nutrition, extremely vital when we talk about low resource areas, especially in tier 4 or rural setups. Smoking, illicit drug use, present of pathological conditions in the fetus, like a fetus affected by infection, a fetus affected by chromosomal disorder, heart problems, some genetic conditions, all of these are responsible for impaired growth. But if you ask me one factor that is extremely crucial for early growth restriction, I would say uteroplacental insufficiency, most frequent cause of abnormal growth in an otherwise normal fetus. Meaning that if the fetus is chromosomally normal, normal on ultrasound, then uteroplacental function is the most important function that we need to understand. So why is it important to diagnose FGR? Because we know an impaired fetal growth is associated with an increased risk of perinatal mortality, morbidity, and even long-term adverse infant outcome, with a follow-up done for almost 10 years into that child's life to study the milestones and his neurodevelopment. Growth restricted fetus, you've shown impaired neurodevelopmental outcome. In fact, there is an increased risk of non-communicable diseases like metabolic syndromes, hypertension, insulin resistance, type 2 diabetes mellitus, coronary heart disease, and even stroke in these children when they grow up. But you have to understand that fetal size, when I talk about fetal size, it is determined through the biometry that we take in every patient. That's the BPD, SC, AC, and FL. But fetal growth is a dynamic process, and it requires assessment over multiple observations of fetal size over time. What I mean to say is, very often in our scenario, in our routine clinical practice, we often come across a patient who comes to you for the first time. She doesn't carry any previous reports. She's not sure about her LMP. She is vague about an LMP, and your biometry does not match with the LMP that she's given. Now, that's a big clinical dilemma and a big ultrasound dilemma. Should I call this a growth restricted fetus? Well, I'm supposed to look at the fetal environment, see the liquor, see the placenta. But irrespective of that, I would never comment on growth based on one finding alone. If I really need to know whether the fetus is growing well or not growing well, I will ask for a follow-up, provided the Doppler is absolutely fine and I can pull on. I will ask for a follow-up at least after 3 weeks to see whether there is a growth happening. If there is a growth happening, maybe this is a small for gestational age baby, or we are dealing with wrong dates. But get this idea that do not call a growth restriction based on one clinical visit alone. What is most important and what has made a pivotal change to our understanding is the use of color Doppler in FGR. But still, when it comes to color Doppler, there are a lot of questions as to how we use them, which vessels to use, and how do you interpret. So I'm going to touch upon this because this is the whole basis of understanding the pathophysiology of early fetal growth restriction. So we study the resistive indices within the fetal and the placental vessels. So previously, when we were learning Doppler, we used to use ratios like RI and SD. So all I want to emphasize here is, though all indexes may good, all the research has been done on the PI. So it's time that we abandon RI and SD and we stick only to PI. When we mention about resistive indices in placental and fetal vessels, we talk about PI and PI alone. Second most practical thing is, when you're doing Doppler, ensure that the fetus is not breathing. If the fetus is breathing, then you will have this irregular kind of waveform, and you're never supposed to measure during this irregularity. What I mean to emphasize is that the Doppler should be done in fetal quiescence and not during fetal movements, not during fetal respirations. And that is one thing that you've got to clearly understand, because this will change your PI values unless you have taken it in fetal quiescence. Now, uterine artery supplies the placenta from the mother's side. So it is going into the placenta from the mother. Now understand that placenta is the barrier as well as the junction between the fetus and the mother. So placental bed is maintained at a low resistance bed. If you maintain it as a low resistance, you will have more flow that will come in. And that is extremely important. And this transition happens at 24 weeks. Early on, when before 24 weeks, the placental bed resistance is a bit high. So when the resistance is high, you generally have a high PI values and low flows. But this has to convert, the placenta has to convert into a high volume organ. And therefore, at around 24 weeks, there is that trophoblastic invasion of the spiral arteries. As a result, the placental bed becomes very low resistance, and then it becomes a low resistance, high volume circulation, and that is what is anticipated of the placental function. So placenta normally should have a good diastolic flow. If there is increase in resistance, for example, there is impaired placentation, there is no trophoblastic invasion of the spiral arteries, or the placenta is very small, placenta is underdeveloped, then you will have increase in the placental flow and resistance. As an effect, whenever there is an increased resistance, the first thing that gets affected is the diastolic flow. So this flow is a diastolic flow. Normally, you would have a good forward diastolic flow. As the resistance increases, the diastolic flow decreases. And as the diastolic flow decreases, your PI indices increase. So if you look at this graph, you have three lines. The median line is the median, meaning that this is the ideal expected value when plotted against the period of gestation. The line above represents the upper limit of normal, or also called the 95th percentile. The line below represents the lower limit of normal, also called the 5th percentile. So my reading should ideally fall between these three lines, not above, not below. So when I say that the uterine artery PI is high, that means it is above this upper limit of normal. In statistical meaning, it is above the 95th percentile for that gestational age. I automatically mean that the placental resistance is very high. So do remember that. Umbilical artery, well, umbilical artery takes blood from the fetus and goes into the placenta. So again, when there is an impaired placentation or when there is a severe placental disease, it will be reflected in the diastolic flow in the umbilical artery. So vessels that supply the placenta normally should have low resistance flow, but in the whenever there is a placental disease, the resistance within the placenta increases and it gets reflected in decreased diastolic flow in the umbilical artery. So that should be the normal umbilical artery waveform in an undiseased placenta. And as the placenta gets diseased, you find that the diastolic flow decreases. It even becomes absent, and in worst cases, it can get reversed. Again, we follow the same principle. The line above is the 95th percentile. We say umbilical artery ratios are high when they are above the 95th percentile. MC, on the contrary, is opposite. The MCA resistance normally goes on decreasing as the brain gets more and more mature. So the brain resistance at term is absolutely low. That is to maintain the cerebral flow. If you see it in the mid gestation, the resistance in the MCA is higher. But whenever there is a growth restricted fetus, then there is less amount of flow going into the fetus. There will be natural hemodistribution of blood, meaning that as a natural mechanism, the baby will send more blood to three most vital organs, the brain, the heart, and the adrenals. So there is a brain sparing effect. The brain resistance suddenly decreases. So whenever the resistance decreases, your diastolic flow will increase and your PI will drop. So the PI is always inversely proportional to the diastolic flow. If your diastolic flow increases, your PI will drop. And therefore, we take an MCA abnormal when it drops below the 5th percentile. So an MCA below the 5th percentile denotes hypoxia. This is a cerebral redistribution of flow secondary to hypoxia. The ductus venosus is a reflector of cardiac function. And we will delve into how this cascade of events happen. But for all technicalities, remember this A wave, that's the third wave of DV. Normally, it is much higher from the baseline. But as the cardiac function starts failing, this A wave starts touching the baseline. It can even get reversed. So when you have a pulsatile DV, it is a sign of cardiac failure. Normally, the A wave is much higher up, but with resistance, you will have decrease, absent, and even reversal in cardiac failure. So these are the changes we expect when we deal with the feti who are vascularly compromised. So go repeating and summarizing this, understand this physiological aspect, that the peripheral resistance in placenta is kept physiologically low so as to get in more flow. And this resistance continuously drops with gestational age, considering the needs of the growing fetus. So we know that the fetus takes about 27 weeks just to reach 1 kg. And it's in the last 11 weeks that it will put on almost 2 kgs. So the growth is exponential. So if the demands are not met by the placenta, we will have a growth restriction. So when we talk about low peripheral resistance, it automatically means that there is low PI, and low PI means that there is a high volume perfusion. Whenever there is a placental disease, there is increase in the placental resistance, which will be reflected in decreased diastolic flow and therefore high PI values. And high PI values means it's a low volume perfusion. So whenever we have high PI, we understand that the perfusion within the placenta is low. And therefore, to compensate for the low perfusion, to improve the perfusion, we put these patients on 150 milligram of aspirin and even for that matter, Lonopin injections so as to thin out the blood, so as to more and more blood can perfuse the placenta and sort of restrict the growth restriction. That is the whole fundamental principle behind adding Lonopin and aspirin whenever we have a uterine artery PI, which is high. So as you've understood, both the uterine and umbilical reflect changes in the happenings of the placenta, and therefore these are called placental tests. On the contrary, as a fetal response to chronic respiratory and nutritive deficiency, there will be hemodynamic distribution, meaning that if the fetus keeps getting a low flow secondary to high PI in uterines, high PI in umbilicals, the body of the fetus will send in more flow into the brain. As a result, this is called the brain sparing effect. The MCA PI will reduce. As the flow further decreases, the heart will try to compensate. It will, overcontract to sending more flow to the fetal brain. But eventually, even the heart will fail. And when the heart fails up, the ductus venosus will reflect a negative A wave. That is A wave on the other side of the baseline. So the MCA and DV reflect changes of the fetus response to chronic insufficiency, and therefore these are called fetal tests. So uterines and umbilicals are placental tests, MCA and DV are considered fetal tests. And consider this ratio, the cerebroplacental ratio, normally at any given point in time, the MCA PI is more than the umbilical artery PI. We've understood so far that the umbilical artery PI or resistance increases in hypoxia, whereas the MCA PI decreases in hypoxia because of the brain sparing effect. So if your CPR is below the 5th percentile for that gestational age, it is called hypoxia, and this is a better predictor for an adverse outcome than just using the MCA PI or the umbilical PI alone. If you use the ratios, you're using two markers together, and that is a better predictor for a poor neonatal outcome. So do understand the CPR. Of course, you would need more of that in the late onset category, but still it is good to measure the CPR in every patient. We cannot start describing or discussing growth restriction without talking about what is small for gestation age and how would you differentiate that from the fetal growth restriction. So by definition, a fetus is considered to be an SGA when its size, that is the biometry, falls below a predefined threshold for its gestational age, meaning that it is not growing as it should. And the most common definition of SGA, therefore, is an expected fetal weight or abdominal perimeter below the 10th percentile for given reference range. There are other thresholds described. Understand that more the shortening, more will be the smallness of the baby. SGA is often considered a constitutionally small fetus, meaning that it is otherwise healthy. Yes, just as a small baby, which structurally is normal and most importantly will reflect normal Doppler findings. But understand that there will be a class of SGA where there will be normal fetoplacental Doppler, but this still can be associated with accelerated placental aging, signs of placental underperfusion, and altered maternal hemodynamics requiring a greater incidence of cesarean section for fetal distress, meaning that not all SGAs can remain SGAs. There may be some undercurrents of growth restriction. There may be some undercurrents of placental underperfusion, and therefore this SGAs can go into growth restriction at any point in time. So the moment you diagnose an SGA, you need to follow up this feti every 2 weeks to understand whether they are growing adequately or they now are going into a growth restricted fetus. So then what is fetal growth restriction? A fetus with an estimated fetal weight less than 10 percentile on ultrasound that because of a pathologic process has not attained its biologically determined growth potential. So we understand that the fetus has to grow well. And every fetus provided that we have provided him a good nutritional background and healthy and a safe motherhood, has a growth potential and therefore it will grow according to its growth potential. But if you have a pathological process like a impaired placentation or a damaged placenta, then this growth will be restricted. And if your weight falls into below the 10th percentile, then this is called a growth restriction. Well, this is not a very straightforward definition because you cannot assess growth by a single biometric evaluation of fetal size, the point I stressed initially. And growth potential is hypothetical, meaning that if I look at my upper class IT patients, they may in fact show a slightly accelerated growth because they're eating well, they're eating nutritious food, they're having enough rest, they have the best nutritional supplements at their disposal, versus somebody who's an undernourished female. The growth of the baby may be lower than expected, yet if the baby is growing, it's small for gestation in that sense. So the most important question that I would want to put here is, does all small baby mean they are growth restricted? A definite no. When I talk about small fetus, as I said, it's defined as a EFW less than 10 percentile for the period of gestation. So the most important thing here is to assign a correct gestational age. So therefore, when we do a third trimester scan, we always look into the earlier CRL scan and we calculate the interval growth. When we calculate the fetal weight, we put it in the percentile chart and see where it falls. So plotting a growth curve is extremely important when you are assessing a fetus suspected of having a growth restriction. You put in the expected weights and the biometry and see how does the trajectory go. Is the trajectory lying in between these three lines? We are sorted. If it is falling below the 5th percentile or going, then it is definitely going down. And this is now getting a growth restricted trend. So plotting a growth curve is extremely important, whether you're talking of an SGA fetus, a growth restricted fetus, be it early or late onset, you'll understand a lot by plotting growth curves. So if you see a small fetus, and if you have excluded a primary defect like a cardiac defect, if you have excluded extrinsic causes, only two causes remain: growth restriction versus small for gestation. So if you compare the two, SGA is also called small fetus, and you can actually prolong this pregnancy up to 37 weeks because the Dopplers here are absolutely normal. Whereas a growth restricted fetus is primarily growth restricted because of placental insufficiency, and therefore there will always be some signs of Doppler adaptation. And in this case, depending on the worsening ratios, you may not be able to prolong the pregnancy up to 37 weeks or even beyond 37 weeks for that matter. So reiterating the fact that when we have a fetus who's small for gestation, meaning EFW, less than 10 percentile for gestational age, if you have an abnormal umbilical artery, PI more than 95 percentile, I will think of FGR. But if I have a normal umbilical artery, I'm going to think of an HGA. But my diagnosis will still remain guarded, prognosis will remain guarded, because I will still follow these patients up. The main distinction between HGA and FGR is the HGA fetus may be small, but not at a risk of adverse perinatal outcome if it remains an HGA fetus, whereas a fetus can be small, not falling below 10 percentile. It may be above the 10 percentile, maybe growth restricted, and still be at increased risk of adverse outcome. That means that if you see a downward trend in the fetal weight, irrespective of whether it is gone below the 10th percentile, this fetus is going into growth restriction, and therefore we need a guarded prognosis about perinatal and long-term outcome. The fetuses with birth weight below the 10th percentile have a higher risk, but those below the 3rd percentile, the risk is the highest. So when we have an EFW below the 3rd percentile, we call it extreme smallness. This is a severely growth restricted fetus. So the fetal size alone is not sufficient to identify a growth restricted fetus unless you have an AC or EFW which is below the 3rd percentile. Then I can surely say that this is an extremely small baby. A drop in fetal growth velocity, that is a drop in AC or fetal weight of 2 quartiles or more than 50th percentile. For example, it was growing well, it was always on the 70th percentile. The patient has come to you after 4 to 6 weeks, and suddenly from 70th percentile, it has now dropped to the 20th percentile. This should alert the obstetrician that this is going into a growth restricted fetus. Doppler changes means that this is a growth restricted fetus, and this is used to differentiate SGA and FGR. But a multinodal assessment is extremely recommended for evaluation of pregnancies, especially CCTG, and used in combination with Doppler. Now we have to understand that though I'm speaking only on the early onset growth restriction, the concept of previously used classification like asymmetric and symmetric growth restriction is no longer used. The terminology IUGR used previously is no longer used. We have only 2 classifications, and that is early onset versus late onset. And IUGR has been replaced by FGR, fetal growth restriction. We have to keep updated with the terminologies as well as the thought processes. So just updating you. So I will be talking only on the early aspect here, but understand that FGR has 2 different phenotypes, and both these phenotypes, the early as well as the late, have a different clinical, ultrasound, and pathological characteristics. So when I talk about early onset growth restriction, it is particularly associated with maternal vascular malperfusion of the placenta. As I said, there is an abnormal transformation of the spiral arteries, pathological features of the placental villi, and multifocal infarction, meaning that there is multiple areas in the placenta which are not perfused with blood, and this malperfusion which leads to placental insufficiency, and this is the most common basis for placenta-mediated growth restriction. And when you actually use preeclampsia screening and you're using SFLT and placental growth factor and the ratios, you will understand that this chronic ischemia of the placental villi impairs placental growth factor secretion. Placental growth factor is a hormone secreted by the placenta itself, and an impaired placental function, meaning there will be impaired PLGF secretion, and this will lead to excessive SFLT1 release by the placenta, and therefore you will have elevated SFLT and PLGF ratios. And this elevated ratios now by recent literature typifies early growth restriction and the associated hypertensive disorders of pregnancy. So these SSLT ratios, PLGF ratios is an indicator that this patient can go into preeclampsia as the gestation advances. So understand that in early onset growth restriction, it is a problem of the placenta. The placenta is underperfused. It could be because the placenta, when formed, is small in size. That is, the base is small in size. Normally, the base has to be more than 10 centimeters. It could be smaller. the spiral arteries that actually erode into the myometrium, that erosion has not happened, and therefore the transition from low volume to high volume circulation does not happen. All of this build up resistance within the placenta, and therefore you have a cascade of Doppler events that eventually follows of early onset growth restriction. And it is a cascade which is very typical, that it follows a certain pattern and it does not jump a pattern. First of all, let me define early onset FGR. The timeline is that if it happens before 32 weeks, if the growth restriction is normal till 32 weeks and the growth starts dropping beyond 32 weeks, it falls into a category of late onset. But if the deterioration happens before 32 weeks, we are talking of an early onset growth restriction. So in an early onset, early FGR, you have malperfusion of the placenta because of a placentation problem. As a result, you have multiple hypofunctioning areas within the placenta, hypoperfused areas in the placenta, building up the resistance further. And what will it reflect in? It will reflect in the two vessels that supply the placenta. The first and foremost, you will have uterine arteries, which will show a high PI above the 95th percentile, meaning that the flow from the mother into the placenta is altered. And as the perfusion further decreases as the gestation age advances, the requirements of the babies keep increasing. You will have the umbilical arteries going next. So first the uterine arteries show high resistance flow. Then the umbilical arteries will start showing high PI above the 95th percentile. As the baby grows further, the requirement further increases, but because of the placental insufficiency, there is further decrease in flow. As a result, the baby is now getting less and less flow. Secondly to this, there is a natural protective mechanism. As a baby gets chronic ischemic, it will try and save the three vital organs, that is the brain, that is the MCA, the coronary arteries and the adrenal arteries. So it puts all three organs in a low resistance bed. As a result, you have a high diastolic flow going into these three organs in chronic insufficiency of the fetus. As a result, the MCA PI drops. So that will be the third step. Step being uterine artery PI being high, second being umbilical artery PI being high, and the third step being that the MCA PI will go down. Still, the baby is trying to put on, remember, the heart is functioning well. There is good conditioning of the heart. These babies before 32 weeks are more resistant to hypoxia, and therefore they'll keep tolerating this hypoxia till a time when further decrease in flow will impair the heart. The heart will keep hyperactively pushing in blood, but at a certain point, even it will start failing. And when the cardiac failure happens, the ductus venosus becomes pulsatile. So when the ductus venosus becomes pulsatile, that is almost an end stage failure, and we are looking at an impending IUFD. So we follow this cascade of events. So as I said, I'll just repeat this once. The placenta is diseased in the early onset growth restriction. So your uterine arteries get affected first. You have high PI in uterine arteries. Then comes the umbilical arteries. They will be the next one to get affected. And you can monitor the PI in umbilical arteries, keep calling them every week or 2 weeks. And you can actually see the diastolic flow of PI increasing subsequently till you may find that The next step will be an MCA PI, which goes down, meaning that there is cerebral redistribution of flow, and the baby is still trying to compensate, but eventually the resistance in the umbilical increases. It may even become absent, or it may become reversed. The heart tries its best to compensate for the hypoxia by beating and supplying flow, but eventually there would come a time when even the heart would fail. There is cardiac decompensation, and when the heart fails, you will have a ductus venosus which becomes pulsatile, and that is almost like an end stage. It is a sign of impending IUFD. So this is a normal cascade of events. So when we know that this is the cascade that will follow, we have an opportunity to monitor this fetus. For example, I find that the fetus is growth restricted, but I find only the uterine arteries are high. The umbilicals are still normal. I will call the patient after 2 weeks. See now that the umbilicals are changing, but the MCA is good. I will call the patient back. Now the umbilicals are high, the MCA is low, but the ductus venosus is still good. I will follow these patients till I feel that the umbilical artery becomes absent or it reverses. I will not wait till the ductus venosus gets reversed, because when the ductus venosus reverses, it means the baby is already in cardiac failure. And these patients have been for the first 10 years in life, and they have showed an impaired neurodevelopmental outcome. So I guess my last stage of endpoint will be an absent umbilical artery or a reversal of umbilical artery when I take out these babies. So an early onset, the main clinical challenge for early onset is how do we manage this feti? It is always diagnosed before 32 weeks. The fetus can be very small, and there will always be some element of Doppler alteration that will follow a certain cascade of event. The biophysical may be abnormal as the baby goes into acidosis, and the hypertensive disorders are often associated. Preeclampsia is associated with early onset growth restriction, and the histopathology of the placenta will show poor placental implantation, spiral artery abnormalities, and maternal vascular perfusion. Perinatal mortality is extremely high in this feta. Before I actually progress into the further thing, I would like to highlight this point that when you find there is a growth restricted pretty early on, like this fetus should have been 17 weeks by date. We have a CRL for comparison, but it's coming to about 14 weeks with less liquor, a very thick placenta, echogenic bowel. And when I actually put in the Doppler, I find that the umbilical arteries are showing reversal of diastolic flow. The ductus venosus is pulsatile, meaning there is congestive cardiac failure. When you find this kind of abnormalities, this is severe early onset growth restriction, and you have to think of fetal infections or fetal aneuploidies as a causative mechanism for early growth restriction. This is, though not common, is something that we got to remember, especially when these feti come to you with growth restriction when you're monitoring them in the early second trimester. So a thick placenta, echogenic bowel, and high Doppler indices favor a fetal infection, which is a common cause of early onset severe fetal growth restriction. The other is aneuploidy or syndromic associations. We also need to touch upon multiple pregnancies. So when you have a selective growth restriction in a dichorionic versus monochorionic, when you have a dichorionic, we treat it as a singleton when we monitor it as a singleton. But criteria are different for monochorionic. First of all, selective fetal growth restriction of one fetus in twins is conventionally defined as a condition in which one fetus has an EFW of 10th percentile for that gestation. But most importantly, the inter-twin weight difference is more than 25%. Then I can confidently say that the smaller fetus is selectively growth restricted. A discordance cutoff of 20% seems acceptable to predict poor outcome. So any which way it is on a downward trend. So I am concerned about that baby. And if both twins have an EFW which is less than 10 percentile, the feti can be termed as small for gestation age, something which we seldom, something is not surprising for a twin gestation. But once a diagnosis has been made, a cause must be sought. So you have to do a detailed anomaly scan and screening for viral infections, especially when you're dealing with early onset severe growth restriction. Sometimes you may actually require an amniocentesis to exclude chromosomal anomalies of that growth restricted fetus. And if you have picked it up in time, if it's a dichorionic gestation, you can go ahead and selectively reduce that fetus using KCL. So again, plotting graphs helps well. We know that one fetus is at the averagely growing and the median, the other fetus is at the 5th percentile. That means there is a disparity at around 29 weeks. So one is selectively growth restricted. And you can pick this up as a growth discordance right from the first trimester itself when you have a CRL difference of more than 5 millimeters, and into the third trimester EFW less than 10 percentile of that fetus, or an inter-twin EFW discordance of more than 25%. So plotting graphs is the most important step there. We find that one fetus is growing as a small for gestational age fetus, but you find that it is growing well, still maintaining that contour, whereas the other fetus has gone into growth restriction. All the percentiles are going further down below the 5th percentile. And if you look at the inter-twin weight difference, it is 37%. And that's a significant fetal growth restriction. So twin pregnancy, when you have a monochorionic one, that is something that we are always worried about. So we have these 3 types of Doppler indices that we will, I'll just highlight this so that it becomes readable for you. We have 3 types of flow, and it is based on these ESOAC guidelines where we look at the umbilical arteries. In type 1, the umbilical artery Doppler waveform has positive end diastolic flow. 2, there is absence or reverse end diastolic flow. And type 3, there is reversal of end diastolic flow. Now, this is something that we decipher based on the Doppler indices. So if Doppler type 1 growth restriction selective FGR for monochorionic twins is when the flow is forward. Your PI may be high, but your flow is still forward. In type 2, there is absent diastolic flow. In type 3, there is reversal of diastolic flow. Of course, the prognosis deteriorates with the progression in the type. So survival rate in type 1 selective growth restriction is more than 90%. Type 2 growth restriction is associated with high risk of IUD, and type 3 is associated with 10 to 20% risk of sudden death of growth restricted fetus, and which is unpredictable. And this is what the dilemma remains. So whether we should intervene in monochorionic or not. Even in dichorionic, it becomes a dilemma because the other fetus is growing well. One fetus is severely growth compromised and the other fetus is still premature. Should we deliver both and have 2 premature feti where one is very sick but the other is normal but still premature, or let one baby go and at least take one baby to term and give the mother one healthy baby. These are the options we always discuss with the patients and the relatives to help them choose what they expect out of us. So always plot the biometry against the growth charts. Fetus A is going well on the 5th percentile, but this is going well because every subsequent scan is in the same trajectory as it is expected, well as the growth restricted fetus keeps going down below the 5th percentile with advancing gestational age. So plotting growth velocity is extremely helpful. And in
So would
early
you make it full screen?
Oh, it's not full screen, it is, I thought. Okay,
No,
so
it was, but it's not right now.
I'm
Yeah.
just sorry. Okay. So decision making is purely based on fetal medicine Barcelona stage-based protocols, where it has been divided into 4 stages. Stage 1 is severe smallness with mild placental disease. So when you have an EFW which is less than 3rd percentile, when you have a uterine artery and umbilical artery which are more than 95th percentile, and an MCAPI which is less than 5th percentile, this constitutes a stage 1 fetal growth restriction. So when I say stage 1, I mean that I have a potential to monitor this fetus and I keep monitoring this fetus till it goes into severe placental disease, that is stage 2. So when I have an absent diastolic flow in the umbilical arteries, that is a stage 2 or a severe placental disease. I'm not discussing aortic isthmus here because aortic isthmus now is quite not routinely used because it is difficult to reproduce by all. But remember, you can use an absent end diastolic flow in umbilical as a good cutoff point. So that's stage 2, and stage 3 is when it goes into early acidosis. So what is a sign of early acidosis? When the umbilical arteries start showing reversal of flow. That's a very good sign that the baby is going into early acidosis and there is an absent A wave in the ductus venosus. And stage 4 is that stage 3 for you, a severe smallness. You see the growth going down with advancing gestational age. You see a very high uterine artery PI. You find that there is a very high umbilical artery PI. You have reversal of flow in the umbilical artery. MCA PI is getting lower. The ductus A wave is getting towards the baseline. So this is coming to about stage 3. And stage 4 is when severe acidosis, when you have reversal of A wave in the ductus venosus, which means that this is a baby which is showing a cardiac failure, and therefore very often you will have an abnormal biophysical profile and abnormal CTG when you have a severely acidotic baby. And that's the reason we do not want to extend our monitoring till stage 4. Stage 3 should be the final cutoff. Here we have a severe smallness, severe growth restriction, a pulsatile DV, a reversal in the umbilical, and that's a sure shot sign of stage 4 severely acidotic baby. Now, the most important challenge for us as sonologists is when to ask the obstetrician to deliver. You have to understand that in early growth restriction, each extra day in utero before 28 weeks decreases neonatal morbidity by about 2%. So for example, if you have picked up Doppler changes at 26 weeks and you can continue till 28 weeks, that each day is 2%, that means by the end of 28 weeks, you give the baby a 14% chance of not going into the NICU. And this percentage is 1% up to 32 weeks. So from a 26 weeker, I can pull on to 32 weeks. I give that much, almost 40% chance for the baby that it will not go into the NICU. Because ultimately, when I am scanning, my goal here is to involve a good NICU and a neonatologist. And my main dilemma is the risk of continuing intrauterine existence without the risk of prematurity. I don't want to give them too premature a baby, but at the same time, if I wait for maturity and the baby goes into severe acidosis, the neonatal is equally helpless. It is extremely difficult to revive a severely acidotic baby. So this is the main confusion. Prematurity versus hypoxia. This is the delicate balance that we need to achieve. And therefore, Barcelona
Your
staging,
volume is lost.
I am okay, Mike. Everything is good here. Are you?
Yeah, we can hear you now, sir. It was just a fraction of a minute break.
Oh, I don't know. Where did you lose me?
Yeah. After this.
Okay. So precisely to balance this out, to balance prematurity with hypoxia, Barcelona came up with guidelines where it says that if you identify a growth restriction beyond 37 weeks, be it any stage, you just deliver the baby because you have achieved maturity. More than 34 weeks, if you have a growth restriction, stage 2, 3, and 4, you can deliver. Stage 1, you can do weekly monitoring. That means when you have a uterine artery which is high, umbilical which is high, MCA which is low, you can still do weekly monitoring. But the moment you have an absent flow in the umbilical or a reversal of flow in the umbilical, you have to deliver those babies. Between 30 and 34, even an absent end-diastolic flow, you do bi-weekly monitoring till you see a reversal, and then you do a deliver at reversal. So stage 3 and stage 4 is deliver at that point in time, the moment you pick up. Stage 1 and 2, you can monitor. Stage 2, especially the absent diastolic flow, you do bi-weekly monitoring and ask the mother to monitor kick count. Earlier you pick up, the more vigilant you will be, because the idea is to continue as much as is feasibly possible. So you will deliver only when you have a severely acidotic baby. Otherwise, stage 1, you will do weekly monitor, stage 2, bi-weekly, and stage 3, you will do a daily monitoring, because as I said, between 26 and 30 weeks, every day gained is 2% chance gained for the fetus. So we become greedy, but not at the cost of severe acidosis or severe prematurity. That is the whole understanding here. So cases of early FGR should be monitored and managed in tertiary level units with highest level neonatal care, and that is most important. You can monitor them, but if you have to deliver them, you have to take them to a center which can have a good NICU if you're talking of a premature baby, and therefore multidisciplinary management is extremely crucial, and monitoring is purely based on Barcelona stage protocols on depending on the severity of FGR and alterations of the Doppler study. If it is before 34 weeks that you're planning to deliver, corticosteroid prophylaxis is recommended, and cesarean is recommended in FGR only when you have an abnormal CTG or when you start seeing a ductus venosus which is getting pulsatile. That means there is a cardiac failure and this feti cannot tolerate the stress of normal delivery. So when you have an absent reverse umbilical end diastolic flow, altered biophysical profile, these become an elective cesarean section indication in cases of growth restriction. Whereas when you talk only of selective small for gestation age fetus, you just perform or keep following these patients every 2 weeks and monitor the growth and do assessment of Doppler. If Doppler is good and the growth is adequate, meaning that the trajectory is maintained and it is a small for gestation age fetus. And you can take it to 38 weeks, but you deliver them by 38 weeks, do not prolong them by 38 weeks. So the most important message here is to identify growth restricted fetus. That is the single most understanding if I would have conveyed to you today. A single biometric measurement of fetal size is not sufficient to evaluate fetal growth, except perhaps when you see severe smallness, that you find the EFW or AC which is less than third percentile. Otherwise, you just plot growth curves. You call these patients again after 3 weeks, see how the growth curve is, and therefore additional biophysical tools have to be included here. Remember, assigning gestational age is essential. So whenever any patient comes to you for third trimester growth scan, always look at the first CRS scan report, the dating scan report, and calculate the interval growth, and you date the pregnancy accordingly. Said early and late onset FGR represent distinct phenotypes of same disease. When we talked about early onset growth restriction, we were talking about the problem of placental perfusion. So the problem lies within the placenta. So in a majority of the cases, it is an impaired placentation. Rarely the problem of perfusion could be because of fetal infection. When you have torch viruses which get embedded within the placental vascular bed, therefore causing microthrombi and increasing the resistance in fetal infections. So this also leads to perfusion problem, and you could have an altered sort of making of placenta in chromosomal disorders, which again will end up with problem of perfusion in chromosomal abnormalities. All three of these can lead to early onset growth restriction. So early FGR is more strongly with abnormal trophoblastic invasion and consequent placental insufficiency. So remember that despite the severity of early FGR, the cascade of Doppler alternation is quite well known. So what it allows us to do is, it allows us to monitor them. So even though when we have picked it up and we have called it at early FGR, if I find that the uterines are normal, the uterines are altered, but umbilicals are normal, I will call this patient again after 2 weeks, see how the umbilicals are. If now the umbilicals are going, but the MCA is good, I will call the patient back till I find that the MCA has gone below the 5th percentile. I'll watch the ductus. If the ductus is good, if the umbilical arteries show forward diastolic flow, I will still monitor this patient till it becomes an absent diastolic flow. If I have an absent diastolic flow and I have reached almost 32 weeks, I'll do a weekly monitoring and take it to 34 weeks. If at 34 weeks I see a reversal of end diastolic flow, I will consider that an endpoint, give betamethasone, give Maxelvan, deliver the fetus, and that's about it. So in early growth restriction, you can monitor the baby and decide when to deliver based on the severe smallness as well as the Doppler criteria. And I cannot drive this point more that always plot growth. Now, if you look at this fetus, right from the days of ultrasound that we are planning from early to late, it is following this trajectory which lies between the two lines, that is the 95th and the 5th percentile, and therefore this would be a average for growth gestational age. It is growing as much as it should. If we look at this fetus, right from the early second trimester, it is falling on the 5th percentile. But all throughout, till about 36, 37 weeks, it still follows the 5th percentile curve, meaning that it is growing, but it is growing on the lower side of normal. It is not gone beyond the 5th percentile, and this is a very classical small for gestational age fetus. In this fetus, you find that it was well within normal at median. And as the pregnancy is going, it is going towards the 5th percentile. And in the 3rd trimester, it goes much beyond the 5th percentile in every parameter. And this is a classical fetal growth restriction. This is a fetus which is small for gestational age. It was always small for gestational age, but in the late 3rd trimester, when there is a placentation, a minor placentation injury, of minor placentation under perfusion, there's a milder placental disease, the demands are very high. That's when it started going down the 5th percentile. So all throughout, it was a small for gestation age. Only in the late 2nd trimester, it start getting restricted. So this is an SGA fetus which developed a fetal growth restriction in the late 3rd trimester. And hence, therefore, always remember that SGA does not correspond to fetal growth restriction, but a small for gestational age fetus can still go into a fetal growth restriction and therefore needs a fortnightly monitoring. Thank you very much for your patient hearing. I hope I would have cleared some doubts that you had.
Thank you, sir. Thank you. Over to the chairpersons for a few words.
Shah sir, that was a wonderful one. Nicely depicting about early onset IUGR. But still, during the management of the mother, mainly the preeclampsia is the common occurrence, sir, and
Yes.
treatment with all the antihypertensives, magnesium sulfate, prophylactic steroids, bed rest. All these will improve the fetus. The Dopplers will be going good on that side. So sometimes it go not to make it worsen. The tree management of the mother is essential to get a good improvement in the Dopplers while continuing the pregnancy. Thank you, sir. It was a very nice lecture.
Thank you, ma'am,
Dr.
for that
Gimni?
input. It is
Yes, ma'am.
extremely, I completely agree with that viewpoint, but that's what I'm stressing upon, that it allows us to monitor. It gives you an opportunity to monitor early onset growth restriction. So if you can postpone the date of delivery by improving maternal health or by improving the fetal circulation, it gives us that window to take it beyond 32 weeks. And that's precisely where an obstetrician plays a very crucial role, by maintaining her blood pressure, by improving the fetal circulation, and by giving the mother that chance to go beyond 32 weeks. So the beauty of ultrasound here is that we can monitor these feti till they either become too acidotic or they become mature. That's the whole objective here.
Yes, sir. Yes, sir. And also whether the mother is responding to those treatments, we can monitor indirectly in the fetus. It's a mirror. It's a mirror to see if the baby is improving in the Doppler velocimetries are improving. It means indirectly that it's a mirror that the mother has an improved health condition.
Dr.
I think
Gimni, over to you.
Gini has something to
Just
say.
one line. Sir, it was such a fantastic presentation that I wish we had more undergraduates, the PGs in gynae and ultrasound. Well, one thing which is scary for us sometimes is that early FGR, if it is caught and we are pulling on the fetus, and there are no soft markers, there are no indicators of intrauterine infection, as you mentioned, the echogenic bowel, etc. That some of these babies have some karyotypic anomalies. They may not be aneuploidies, they may not have soft markers. That is the lingering fear in your mind when you know the 1.2 kg one is delivered at 33 weeks after pulling so much. So I think that is an area which one has to be constantly aware that the outcome. Some babies don't have any soft markers.
So I completely agree with you, Dr. Gini. When these patients come to you at 16, 17, 18, well, at that point, you suspect a karyotype abnormality or a fetal infection. But even at that point in time, we would have to wait till completion of 20 weeks, simply because the viruses are secreted in the amniotic fluid by the fetal urine. So the fetus urinates the virus into the amniotic fluid. And because the fetal urination happens much more significantly beyond 18 weeks, in these cases, we have to wait till completion of 20 weeks, where we have an opportunity to do an amniocentesis and test for torch PCR as well as a microarray. So in this feta, if we can diagnose, get some answers, we have answers. But if this fetus comes to you in the late gestation, you can just hope and pray that this is chromosomally normal.
Yes. Thank you, sir.
Right. Ma'am, please unmute yourself. Dr. Asha Jain, ma'am, please unmute yourself.
Mohit sir, when I told you that it's going to be a 40-minute lecture, you said
Maine
40
dekha, sorry, I'm so
minutes.
sorry. I'm
And
so
you
sorry.
have spoken for more than an hour.
I'm
And
so
because
sorry.
you were answering so many questions, I didn't feel like interrupting. We
No, I'm
really
so
learned
sorry.
a lot.
I'm
There's
so
no
sorry.
sorry about it, sir.
Captivating. I
Because
had no
it's
problem
going
with
to
my
help us.
fan.
It's going to help us,
Yes.
in the panel that we are going to do now, because you have
Okay.
actually answered everything. So it would be more of a rapid fire. And that is why I did not keep early and late together. Because we need to understand one. We had one session only on the placenta.
No.
So
I
that
actually,
is why that basic,
I should
we
have
need
kept
to
time.
bring up and put it inside.
I didn't keep track of time. I'm really
That's
sorry.
that's
It was a pleasure
absolutely
listening
fine.
to you, sir. Time apart, it was a pleasure listening to you. So we have no complaints on
A
that.
pleasure, ma'am. He held us together in place and captivating.
Yeah. Thank you. Thank you so much.
And
Thank you
those
so
who
much.
joined on YouTube didn't leave it. So they're still there. So you don't have to worry. Thanks a lot, sir. Thank you from
Okay.
the bottom of my heart for taking this difficult topic in its entirety.
Well, thank you so
He's
much.
from
Thank
the
you so much.
gynecologist point of
Yeah.
view.
Thank you, Dr. Asha, Dr. Gini, Dr. Sujayasri, Dr. Padma, all of you.
Thank you
Thank you
so
so
much,
much.
sir. It was our pleasure,
Thank you.
honestly.
Bye-bye.
Thank you, sir. Thank you. So, Sujya,
Yes,
I
ma'am.
would ask you to introduce the panelists,
Yes.
and
Sure,
then
ma'am.
I will share the panel.
Okay, fine, ma'am. So moving on to the panel discussion, I would firstly introduce our expert for today, Dr. Harshad Ruprela, sir. He is a director of Ruprela Diagnostic Center at Raipur. He is also the state vice president and central body executive member, Society of Fetal Medicine. He has completed his MBBS, DMRD, DNB from Mumbai. He has numerous publications and awards to his credit. He has received the Best Oral Poster Presentation in National Neurology Conference, which was held in Mumbai 2012. Areas of interest are fetal growth and Doppler, fetal echocardiography, vascular limb Dopplers, and endoanal ultrasound. So welcome to today's session, sir. Moving forward towards the panelists. Yeah, a pleasure, sir. So moving on forward to our panelists. Firstly, we have Dr. Manu Singla with us. Madam is a secretary of Ludhiana OB-GYN Society. She is currently practicing at Singla Hospital at Ludhiana for the last 20 years. She is a life member of FOXY, IMS, SFM, presently secretary of our Ludhiana OB-GYN Society. And her areas of interest are high-risk pregnancy and ultrasound. She has participated as a faculty in numerous state and national conferences. Welcome, ma'am. We have Dr. S. Padma with us. Madam has done her fellowship in gynec oncology from Netherlands. She is a senior consultant and head of department at Meenakshi Mission Hospital and Research Center, Madurai, Tamil Nadu. It's a DNB training center. Madam does laparoscopy, hysteroscopy, and she's also a robotic surgeon. And she has received the award for Certificate of Excellence in 2023 by European Society of Gynec Oncology. She's a member of ESGO, AAGL, IAG, ISUOG, and IUGA. She's currently the president of Madurai OB-GYN Society. She's also been the treasurer of Madurai OB-GYN Society, past president of Madurai Society. She's been the past joint secretary of Association of Gynec Oncologists of India and past secretary of Vijayawada OB-GYN Society. She has been the organizing secretary of the National Conference of AGOI, organizing committee member of Dakshin South Zone, FOXY Madurai. She has organized many workshops in laparoscopic gynec oncology, urogynec oncology, and also fetal medicine. She has presented a guest lecture on PPH at SMFM conference in the US and also in the World Endometriosis Conference in the US. She has presented numerous papers at national and regional conferences. It's a great honor to have you with us, ma'am. Next slide, please. Okay, moving on, we have Dr. Samira Aluri with us. Madam is a senior obstetrician and gynecologist, and she also is a preventive oncologist. Mehul, can we have the next slide? Yeah. And Madam is working at Vijaya Vamsi Clinic, Somajiguda. She's also a consultant at Sri Sri Holistic Hospital, Nizampet. And Madam has done her master's from Osmania Medical College, and she has also done her diploma in ultrasound, WHO Collaborating Center, Zagreb. I hope I got it right. And her areas of interest are practical obstetrics and high-risk pregnancy, fetal medicine, adolescent health, contraception, non-descent vaginal hysterectomy, preventive oncology. And Madam has presented many papers in national and international conferences and also chaired sessions. Welcome, ma'am, to today's session. Moving forward, we have Dr. Aloknanda Ray. Madam is a consultant at Tata Main Hospital in Jamshedpur. She has been the past president, Jamshedpur OB-GYN Society in the years 2012 to 2014. And she has also been the Foxy East Zone Coordinator for Medical Disorders in Pregnancy. She has received Apex Award for Total Quality Management Project. She has also received an Innovesta Award Corporate Services, Tata Steel, Breaking the Communication Barrier Drive in COVID 2022. She has publications in Cochrane database reviews. She has also received a best paper in 2015 and 16. And she has clinical presentations at various audits. And she also has received the Piroshaw Best Publication Award for TMH Tata Steel in 2015 and 2005. She has received the Best Lady Speaker, All India Steel Medical Officers Conference. She has received the first Certificate of Merit for Proficiency in MD in her Master's OB-GYN JIPMER and also at SSKM Hospital, Calcutta. So, Madam has almost 150 citations and publications.
Small, make it short, dear. Please make it short.
We also have Dr. Tushar Ranjan Hirsa with us. He's a director of HR Diagnostic. He's a consultant at Life Care Scan and Research Center, and he has presented many papers in regional, state and national conferences, and he's a lifetime member of IRIA SFM. And lastly, we have Dr. Anu Goyal with us, who's the Secretary of Mathura OB-GYN Society. So I welcome all the panelists to today's session, and I request Dr. Asha Jain, ma'am, the moderator, to please take over.
So thank you, Sujeshri. And as you all know, I have just 4 cases. Yeah. So my slides are visible. So
And the
we
visible,
will
ma'am.
be. So I request all of you to nominate me from your societies for Food, Drug and Medico-Surgical Committee. And this is the basis of what we are going to discuss now. So for growth restriction, we have maternal factors, we have placental and cord abnormalities, we have fetal factors, and we also have infections. So in the maternal factors, basically everything that makes the fetus grow slow is because there is placental insufficiency or there are reduced nutrients. So we come to the first case. I request all my panelists and experts to please put on their videos. Please put on your videos.
My video is not opening.
Dr. Samira?
My video is not opening. That's why, that's fine. I'm unable to.
No,
Okay, fine,
there's
ma'am, that's
something
okay.
wrong at your end. So we come to the first case. It's a 32-year-old Gravida 2 Para 1. She presents at 28 weeks gestation for a routine perinatal visit. Her first pregnancy resulted in a healthy term infant. This time, the fetal growth is lagging behind expected parameters. Ultrasound reveals a decreased amniotic fluid volume, and there is an abnormal umbilical artery waveform, which suggests placental insufficiency. Now, the patient denies any significant medical history or substance abuse. So, further monitoring and early delivery is what we are going to discuss. So, Dr. Samira?
Yes, please.
Please log out from one instrument. There's a lot of echo because of two instruments.
Yeah.
Log out from one. We also have Dr. Sarita Kumari, the Secretary of Jamshedpur Society. Dr. Sarita, would you like to join in? So now the questions are, what could be the cause of this abnormal growth of this fetus? What are the different causes that you can enumerate? Anyone can answer the question.
Ma'am, according to history,
Yes.
there seems to be either placental or fetal causes of this IUGR. The placental causes, they may be like single umbilical artery, circumvallate placenta, confined placental mosaicism. There may also be abnormal cord insertion. And fetal factors may be like there may be any congenital heart disease or any
There is a little less liker. There is a little less liker. That is the one thing that we have.
More towards placental causes. It is more towards placental causes.
So, Dr. Harshad, would you like to add something here?
Ma'am, it may be due to a pregnancy-induced hypertension.
But
well, the mother has nothing wrong with her. There is no hypertension or anything. It's just a routine examination that we have seen. So
she might have moved to a higher altitude, change of place, or under stress for any reasons.
She could have been
not able to follow the lifestyle, regular lifestyle, not taking adequate amount of fluid.
Okay. Yes, Harshad, you were saying something. Would you please adjust the camera so we could see your face?
Yes, I don't know if we can.
Yeah. Now we can see. Now we can see.
Yeah, ma'am. In the history, you mentioned that she has decreased. The report said it has decreased liker, and she has no previous history of any IUGR in the previous pregnancy. Currently, in umbilical artery changes are present. Yeah, this is the. Can you just show me the first slide, ma'am? Yeah. So reveals decreased amniotic fluid, and Doppler indicates abnormal umbilical artery waveforms suggestive of placental insufficiency. So here you have only mentioned, ma'am, the cause is placental insufficiency. So it could be because of hypertension, because that is one of the commonest cause of placental insufficiency, maternal hypertension. So that is one thing. Because in this case, you have mentioned itself that the umbilical artery waveforms are suggestive of placental insufficiency, and the most common cause of placental insufficiency is maternal hypertension. And
okay,
yeah. The other practical thing, I feel that the pressures have to be recorded by the practitioners, by themselves. Sometimes there may be a discrepancy in noting down the blood pressures, and we may not be knowing that she's having a medical problem. And we lose precious time sometimes.
That is very important, very, very important. So when you are diagnosing FGR, which is the growth chart that you're going to follow?
Hadlock.
Okay, anyone wants to defer to that?
Ma'am, whatever growth chart you have to follow one single chart always, because you cannot change your growth charts in any pregnancy. Suppose you are following
No,
a pregnancy,
agreed. But like, there is something standard that
you
is
have Indian growth
recommended.
charts also. So you have Indian growth charts also from north side and south. Yeah, there are Indian papers also giving growth charts for North Indian children and South Indian children also. And then we always follow the standard growth charts headlock, which is generally there in the machine, which is provided in the machine. Most of the vendors supplying the machine.
Dr. Samira,
Yes.
I wanted to ask you one thing. What is the problem between an intergrowth chart and a standard Hadlock chart? What's the difference? And which would you consider using?
I cannot explain this now, but the Hadlock chart, I feel since long time in the practice, and what Dr. Harshad has just told, they are giving in the machines. I'm very happy with the Hadlock pertaining to the estimate birth weight and the result we see after delivery. I cannot.
Okay. So actually what has happened is, when everything was standardized, it was a multi-center study across the whole world. And what they found was that when everything was standardized in pregnancy, all the babies, irrespective of race, grew the same. Okay. And that is why race-specific growth charts are not recommended. That is the only difference between an intergrowth chart and the chart, which is the Hadlock, which is being used. Okay. So now we come next. How is this patient going to be followed up? She is 28 weeks. There are umbilical artery changes. Okay. There is diminished flow in the diastole. Now, what are you going to do? How are you going to follow up this case?
Shall I take it up?
We can give her a steroid cover, and if she is permitting, if we are expecting that the pregnancy will not continue beyond 32 weeks, then we should also give neuroprotection, magnesium sulfate for neuroprotection.
Who is speaking? May I know?
Ma'am, this is Dr. Sarita.
Okay, apna video on kariye, please, because otherwise I can't make out who's speaking.
Sorry,
I can
ma'am.
only see, 4 people on my screen now. That's why. So actually, there are only minimal changes at the present moment, right? So do you, I want to ask this of Dr. Padma. Dr. Padma, when would you advocate giving steroid, and when would you advocate giving magnesium sulfate?
Steroids is when the patient has to go for an early delivery in this kind of a situation.
In this case,
Yeah,
does
yeah,
this
in this
patient
case.
go for an early delivery?
Yeah, it's just a follow-up and monitoring of the patient, and it depends on the diastolic blood flow. If the diastolic blood flow is adequate, then we can even try postponing giving the steroid to a little later time also. And because if once we give steroid, then the effect is going to be there for a week. And then the question arises whether we'll have to repeat and other things. So to avoid those type of controversies, we can follow up. And when we feel then the delivery seems imminent, then at that point of time, we can give it.
Yeah, agreed. Because with only minor umbilical artery changes, what Dr. Mohesha just showed, stage 1, stage 2, stage 3, and stage 4. So this would still be just stage 1 or stage 2. So we are going to monitor her weekly. We are not planning delivery within a week, and because we are not planning delivery within a week, we are not going to give steroid at the present moment. We are going to just follow the case. And when we plan delivery is when we are going to give her steroid. So how often will you call her for monitoring? Will you like to admit her?
No, but once again, this monitoring depends on the diastolic flow. If she's having a good forward flow in the diastolic phase, then it's okay. We see her every week or something like that. But on the other hand, if the flow decreases, if the PI keeps increasing, then there is absent diastolic flow. Then probably the frequency of monitoring needs to become more, maybe twice weekly, thrice weekly. And if it is reversed, then even twice a day we may have to monitor her. And
So at this moment, what are you going to do? You're going to admit her or you're going to call her in a week?
Not at all. Not at all. Just call her a week later.
So you've already told how you're going to monitor her. And now my question to you, Dr. Sarita, what are your triggers for delivery? When are you going to decide that now this patient needs to deliver?
Can I add little at this point of time? Suppose the lady, now there is no medical problem and the Likers are low. So I'm Dr. Samira.
Yes, Samira. It's not working. Your
my
camera
video
is not working.
not denied. The camera access is denied actually.
No.
So,
Mehul, would you please look into it? How can she have a denied video? Mehulji, please just see that her video gets on.
So I just want to, I will depend on the amount of Liker at this point of time and also the placental grading. And my experience, practical experience in such cases, I just put the lady on aspirin also. It is helping out for some ladies. If there is no hypertension also, any family history of little hypertension in the parents or so, a less Liker, little advanced placental grading.
Dr. Samira, do you want to add aspirin at 28 weeks?
Yeah, practically. Very few cases I added.
No, but I'll tell you, there is no scientific basis for that.
No scientific basis, correct.
No scientific basis,
yes,
and I don't think that should be said here as a recommendation because we talk of guidelines. Yes, Dr. Padma.
Yeah, can I add something? See, what happens in these kind of patients, there is a risk of an imminent delivery. And when you add aspirin at this point of time and you have to take up the mother for an early delivery, you are stuck with the mother on an aspirin and whom you have to even take up for an operative delivery. And the risk also is there. And as such, aspirin at this stage is not going to help her at all. Because the damage has already happened.
Yeah, because the placentation has been completed by latest 22 weeks. There's nothing more of placentation that's going to be done here.
I have to correct myself. Doppler's being normal. Doppler being normal.
No, here even if your Doppler is normal, ma'am, at 28 weeks you don't add aspirin. Yeah. So now, what is the trigger for delivery? Mohit Shah sir explained it very well. What is your trigger for delivery?
Ma'am, can I speak?
Yes, please.
Ma'am, actually, trigger for delivery is, as Mohit sir explained, that it depends on the stage of the Doppler. And if you have ductus venosus reversal, or you have umbilical diastolic flow reversal, and then you have severe cardiac compromise. So in that case, we need to take a call for delivering of early IUGR cases. This is a case of early IUGR.
Yes. We are discussing early IUGR. And Tushar, I haven't seen you. Can you also join in? Dr. Tushar? So as you correctly said that we have to, your hand is in front of your camera.
Okay, sorry.
Okay? Yeah, now it's better. So here the trigger will be reverse flow and DV reversal is the point because each day gives 2% increased survival. So that is when we are going to, that is the trigger. In the early IUGR, the trigger is not CTG or anything. The trigger is DV reversal. In late IUGR, it is biophysical profile changes that are going to trigger delivery and not ultrasound. So here the mode of delivery would be, what would be the mode of delivery? Dr. Sarita?
Ma'am, since it's early IUGR, the patient, we can offer induction of labor, but we have to explain
with an abnormal Doppler.
No,
with an abnormal Doppler, see, your trigger of delivery is an absent reversal of flow in the ductus venosus.
If there is reversal of Doppler flow, then cesarean section will be better, ma'am.
So here, there is no other option. You're going ahead and doing a cesarean section. Now, what are the perinatal problems that you expect?
So all IUGR features like respiratory distress, intraventricular hemorrhage, necrotizing enterocolitis, metabolic
acidosis. You muted yourself, Dr. Samira. Yeah.
So all the prematurity problems like respiratory distress, intraventricular hemorrhage, necrotizing enterocolitis, metabolic problems, hypothermia, all those things which will be taken care in NICU.
Correct. Now, Dr. Manu, I want to ask you, how will you safeguard yourself medico-legally for the decisions that you're going to take? Anyone else can answer here? Because here, the patient is not really understanding what is wrong, right? So how are you going to protect yourself medico-legally? What is going to be the content of your counseling?
Ma'am, we have to explain the fetal outcome in patient's language, and the decision should be shared. We have to explain everything about the neonatal outcome also, that these baby may have a neurodevelopment delay in the first few years of life. And if the patient and party agrees for the cesarean section, then only we should terminate the pregnancy. We should not insist that the patient needs cesarean section. That's why you have to take decision of cesarean section. It should be a shared decision.
Okay, so do you want to also involve the neonatologist in helping the patient take a decision?
Counseling, we should involve neonatologist also. If we have facility of neonatologist in our hospital, 24 hour. 24.
If you don't have a neonatologist, you cannot deal with this patient because it needs a high efficiency perinatology unit. Dr. Padma, you want to add something here?
Yeah. See, actually, no, when we deal with these kind of cases, it's good that the radiologist and the sonologist and the obstetrician have a dialogue between them to assess the triggers for delivery. And once the decision for trigger of delivery is made, then a good dialogue between the obstetrician and the neonatologist come in. And the neonatologist is a part of the team, and they have to be kept updated about the baby's progress also, fetus's progress also. And better these cases are dealt in a center, in a higher centers where all three of them are there. And if the obstetrician are positioned to monitor the Dopplers by herself, then that is the best.
Yeah, but it's always good to be medico-legally safe. So your documentation should be complete. Positive and negative consent has to be taken. And decisions, as far as possible, should be shared decisions. Anyone wants to add anything to this case before we proceed to the next?
Ma'am, at least one Doppler should be by the radiologist who is trained in doing ultrasonography, because it will help in medico-legal cases.
Harshad, what do you say to this?
Ma'am, I will just say that if you want to safeguard yourself medico-legally, you need to first document the stage with the correct report of the fetus, what you have scanned, and mention the stage of the IUGR. Since this is an IUGR child, and whatever your management, it depends on the stage. So whatever you have taken step, delivery or you're calling weekly, and suppose if you are calling after 1 week and by chance the fetus does very bad, which is rare, but it can happen. So you have done the management based on the stage, and which will be acceptable by the board of members, even if it is taken ahead. So I think stage wise staging is very important in the report, and stage wise management is the call what we have to take here.
And another thing Dr. Mohit had told us also in his talk, whenever we are not able to pinpoint any specific etiology prior to the, say in this case, no, we are not having any, I assume that there is no PIH or there is no other cause to say that why the baby is going for an IUGR. So in that cases, probably there is some sort of a genetic problem also, which we are not able to pick up at that point of time, and which may get revealed in the neonatal period.
But
So
for
that sort of
genetic,
counseling. Yeah, that counseling also needs to be done.
But ma'am, for genetic, I think whatever genetic evaluation has to be done is during the NT-scan, first trimester or the second trimester, when we have the NT-scan window period and the anomaly scan. So whatever risk ratio that time which has been calculated and by combining all the factors of ultrasound and biochemical markers. So based
So
on
that
and the
is,
material age.
yeah,
So if
that's for,
already I think already this thing genetic valuation must have been done based on this risk ratio before.
no, that will be
But
only for the
Harshad, we
aneuploidies.
would, you know, not see 100%.
Yeah, that's
Yeah,
only
that is
for
Whatever
true.
you are doing.
aneuploidies.
So this is something that is not coming up in that. And the
Yeah, that's
patient
what.
has now
Then,
landed up with a growth retardation.
See,
yes,
some
ma'am.
of
But
these
then,
inborn errors of metabolism and all, no, there's no way we can pick it up in the antenatal period
yeah,
unless
that's
there is a
true.
previous affected child.
So, but then we all be medico-legally charged for that, then in that case.
Yeah, then that needs to be explained and should be a part
Yeah,
of
yeah.
the counseling.
Yes, yes, yes.
So now we come to the second case. It's a 25-year-old primea gravida. She is a type 1 diabetes. She has presented at 24 weeks. She has suboptimal glycemic control. She is taking insulin, but in an erratic way. Ultrasound reveals fetal growth below the 10th centile. Due to concerns about maternal fetal complications, due to poorly controlled diabetes, including IUGR and preterm birth, the patient is referred to you, a gynecologist, a fetal medicine specialist, for closer monitoring and management adjustments. So, my first question goes to all gynecologists. Is it possible to have growth retardation in type 1 diabetes?
Yes, ma'am. If there is feature of vasculopathy, then there is chances of growth restriction even in type 1 diabetes mellitus.
So that is a very important point because all of us gynecologists have that mindset. Diabetes means a big baby. But you can have a small baby in type 1 diabetes. So you've already explained the mechanism. So what are the diagnostic criteria here for FGR? Dopplers are all normal. What we have is just the size, which is less than the 10th centile.
We need to have a growth chart plotted for these kind of babies. So,
yes.
So when there is
now
a significant drop, then
now
we can.
here there are two problems. One is that uncontrolled type 1 diabetes, and the other is the growth retardation. So how are you going to manage this?
We have to.
First, we have to confirm the dating because she has presented to us at 24 weeks of gestation. We have to see that whether
no, she is a regular. She is correctly dated. Then
we have to perform serial growth scan, ma'am, to see whether it's SGA or FGR baby.
How are you going to manage the mother and how are you going to manage the fetus? Two different questions. Dr. Samira?
So I feel that we have to admit for short time for the control of blood sugars. I usually counsel my patients, most important for sugar control is regular diet. They have to take regular diet and the sugar monitoring and insulins, whatever. If they are on tablets, switch over to insulin, most important, because insulin control of blood sugars will be more better without much fluctuation.
She is type 1 diabetes, so she is already on insulin.
Insulin, yeah, okay.
She's type 1 diabetes.
Okay, okay.
So you have, yes, Padma?
Yeah, actually, in the problem with type 1 diabetics is there is marked fluctuations in the sugar levels in the mother. At one point, she's hypoglycemic, the other point, she's hyperglycemic. So the nutritional therapy and the insulin need to be monitored based on her hypoglycemic levels. She should not be allowed to go for hypoglycemia. And
so does maternal nutrition therapy have a role?
Yes, definitely. Along with insulins and diabetic, along with all.
Okay.
Diet, exercise. Exercise means I tell my patients to go with Sukshma Yoga, Pranayam. So at regular intervals. Sleeping well at night, most important. And then the monitoring part. Strict monitoring of the part.
How frequently do you want to monitor her sugar? How frequently?
If the blood
She is
sugar,
hospitalized with you. So she is hospitalized for 3 days, 5 days, just for, diet and insulin balance. So how frequently are you going to monitor her sugar?
a fasting blood sugar, a post breakfast blood sugar within 2 hours, then post lunch blood sugar within 2 hours, random blood sugar at 7 p.m., post dinner blood sugar within 2 hours, 5 times. But nowadays, the endocrinologists, they are saying 1 hour levels recently at my setup. I don't know.
Can I add something?
Yes.
See, these people are better off. I mean, though it is not possible for everyone and then they can't afford, that's a different story. But then they are better off by having a continuous sugar monitoring. And then they
Yes.
have a subcutaneous pump or something for a better control.
Agreed. That pump is
recently
expensive. It's 10,000 rupees and it lasts for 14 days.
Yeah, it's quite
but that is the price for getting proper control, because she would need it for 3 months, right? She's already at 24 weeks.
So recently, my experience, one of my cousin's daughter, she is type 1 IDTM, and she has this continuous monitoring of blood sugars. She had little vomiting, little upset, and the pressures are very low, 60 like that. They are so worried about not, but she took all the sugars and all the sugar is not raising up. And then ultimately this thing is that sensor is not working properly and they have to switch over to sugar monitoring.
Dr. Samira, there will always be technical errors.
Technical errors.
Because we are now sitting here on a Zoom and it might just go off. So, but that is not an everyday thing. What we have to understand is that if there are 100 sugar monitors, how many are going to go bad? What percentage is there? By chance, anything can happen. So with those 5 sugars that you already said, now it is advocated to do one between 2 and 3 a.m. when the patient is asleep. So that is the time when, if there is hypoglycemia, IUGR chances are higher. IUFD is also more in case of hypoglycemia. So now you have stabilized her, she's on insulin, she's on monitoring, and her sugar levels have averaged out. Now, how many weeks do you want to carry this pregnancy?
I just want to clear one doubt. Suppose the lady is sleeping very well at midnight. That monitoring is very nice, 2 to 3 a.m. But interrupting her sleep again.
It's all right. It's just a simple break, and her husband can do it. She doesn't have to do it herself.
Great. She need not get up also.
Ma'am, in
husband
our hospital,
has to do it.
Yes,
Dr. Sarita?
Ma'am, in our hospital, we do at 12 midnight to see hypoglycemia.
Yeah, actually, the recommendation is 2 to 3 because that is when there is a balance of hormones.
That's a great thing. I will try to implement this. This is so nice.
But the husband can do it.
Yeah.
And if she knows, she'll just do like that and then it will be okay. So,
and
yes,
actually
Dr. Padma?
Actually, these midnight hypoglycemias are the one which induce a reflex hyperglycemia at early morning. And when we just check the morning 6 a.m. sugar and we feel it high, and we should not keep increasing the insulin. This is very important.
So that is the most important take home for us gynecologists here. So now her sugar and everything is okay. Her Dopplers were normal. So we are going to check her in how many weeks? 1 week, 2 weeks, 3 weeks?
2 weeks interval, ma'am.
Initially 1 week.
Padma?
Yeah, if her Dopplers are doing good, then probably 15 days also should be fine. And I mean, a proper sugar control also.
So the
is
recommendation is again of 2 weeks, as Dr. Sarita already said. So you do a Doppler in 2 weeks and the growth is assessed in 3 weeks. And you have carried her to 36 weeks. So do you want to deliver her at 36 or 37 or 38?
Ma'am, we have to see matlab biophysical profile should be assessed in the meantime, because the decision for delivery will depend upon if the Doppler is normal. We can go up to 37 weeks if the Liker is normal. If the Liker is less, then only we have to take a decision of termination. By seeing
Dr.
other
Padma,
biophysical profile also.
36, 37, 38.
No, when things are all quiet, calm, settled, then she can even go up to 38 weeks. There is a reason I think behind this. The reason being the lung maturity for the mothers of the babies of mothers who have diabetes a little delayed. So what could be okay delivery at 37 for a normal woman? The babies for a diabetic mother, their lung maturity is a little later. So maybe 38 will be better if things are okay.
Dr. Samira?
I agree totally with Dr. Padma. Monitoring.
Dr. Manu? So, if you remember the second last slide that Dr. Mohit Shah sir said, if the baby is less than the 10th centile, even if everything goes well, you do not go beyond 37 weeks. Simple.
Okay.
There is a guideline that you can give steroid even at 36 weeks to such babies, and the outcome is improved. Okay? Now, if the Dopplers are normal, are you going to induce her? And if you're going to induce her, then what are your criteria for induction? Are you going to do a stat cesarean or are you going to induce her?
Practically,
He's 37 weeks.
Yeah, when the parameters are normal, say the biophysical profile is good, the CTG is good, the Dopplers are fine, then we can always give a vaginal delivery with close monitoring. Yeah, continuous
So, means
CTG.
what are your criteria for induction?
Criteria?
Come on. Obstetric
Bishop
indication
score
yes.
very favorable. And first
Bishop score, vertex presentation.
Adequate Liker, and continuous monitoring. Pressures, no other medical problems.
No, now you have induced her, and now 6 hours have gone by. You waited. Another 12 hours have gone by. What are your triggers for doing a cesarean section?
No.
Yes, Dr. Sarita?
Ma'am, in our institute, we follow Servigel at 6-hour interval, maximum 3 doses. And even after 3 doses, there is if there is Bishop score is unfavorable, then only we go for cesarean section. Or if there is any concern in cardiotocography.
CTG is normal, but there is nothing is happening to her cervix. It became a little patulous and then nothing happened.
If the Liker is okay.
Liker is okay, but she's 37 weeks and you are inducing her.
Ma'am,
and for 12 hours, nothing has happened.
We wait for 18 hours. We give 6 hours, the Servigel at an interval of 6 hours. Even after, if 3 doses, the Bishop score is unfavorable, then we call it failed induction and we go for cesarean section.
So actually at 37 weeks, it's invariably going to be unfavorable only. So, I mean, if things are okay, then I would rather wait a little longer. No fixed like 3 doses, 4 doses. We'll even wait a little longer.
See, that is where you're all experts and professors. So I'm asking you that this is a dilemma that every gynecologist is going to face. The guideline says deliver at 37 weeks. Cervix is unfavorable. It's not responding to your induction. So are you going to be more heroic and put in a Foley's and try induction, or are you just going to go ahead and do a cesarean? Manu ma'am? Can you hear me, ma'am? Manu ma'am?
Yes, ma'am. Yes, ma'am.
Ma'am,
in diabetic patients, sudden hypoglycemia and sudden IUDs, many times they occur. So I won't
and the baby has IUGR, has growth restriction.
Yes, ma'am. So I will do a planned cesarean. I will not go for induction.
I will also go with cesarean.
Okay. So most probably it is going to be a 37-week cesarean section, right?
Yes, ma'am.
Most probably, unless the cervix is favorable and it's not a primary, it's a multi and the cervix is favorable and responds to your induction. But you are definitely going to give a trial of induction if everything is fine.
Yes,
So
ma'am.
that is as per guidelines. Now we have 2 more cases and 10 minutes. So it's a 29-year-old pregnant woman. She's at 30 weeks. She has fever, malaise, abdominal pain. She had UTI. Now, in her scan, it's the abdominal circumference that is lagging. Her blood tests are showing CMV infection. And now, can recurrent UTI cause IUGR? Come on, let's be quick. This is going to be rapid fire. We have to finish in 5 minutes. Can recurrent UTI cause IUGR?
Yes.
Yes, it can.
Yes.
Okay. Can it cause preterm delivery?
Yes, it can.
Yes, it can.
How do you diagnose a CMV infection?
Torch PCR,
Stores PCR.
If IgM is positive.
IgM positive.
IgM is positive, then you're going to go ahead and do an amniocentesis, right? Then
Yes,
you're
ma'am.
going to do an amniocentesis. Now, do you test every pregnant woman for
Asha,
torch
can
infection?
I add
No.
something here?
No, ma'am. If there is
Yes.
history of recurrent pregnancy loss, then only.
See, it is not
Yes, Dr.
necessarily.
Padma.
Yeah, it is not necessarily only IgM. IgM will get it only in the primary infection. If it's a reinfection, CMV is something which is known to go for reinfections. So in that case, then we will have to check for the IgG titers, and we have to go for something called an avidity test.
Avidity
If the
test,
avidity is
right.
low, then it is a recent infection and chance of infection is more. If the avidity is high, then probably the mother and the baby are protected.
Okay. So now, torch test, do you do it in every pregnant lady? No.
Not at all.
No.
So now, you have already explained how to interpret the result. Now, do these infections recur? CMV does recur. Toxoplasmosis also recurs, right? How do you suspect CMV on ultrasound? Dr. Tushar, would you like to say something here?
Yes, ma'am. On ultrasound in CMV, you can see periventricular calcifications and ventriculomegaly, and we can also get microcephaly. Intrahepatic calcification also sometimes seen, and placentomegaly also can be seen in CMV infection. So all these are pointers which indicate CMV infection.
Yeah,
in
but
fetus.
see, if she gets that CMV activation in her 3rd trimester, then are you going to see all this?
In 3rd
If she
trimester, we can
had,
get.
what will you get if she has been infected in the 3rd trimester?
Ma'am, we can get intracranial calcification and periventricular cysts and intraventricular adhesions also will get.
Okay. So if we see any of this, we have to suspect CMV and we have to do an amniocentesis. For treatment, are you going to give her antivirals?
So once again, depends like when she acquired the infection. If it's in the 1st trimester, then yes, valacyclovir helps because it reduces the, the chance of progression or transmission of the virus to the
She got
fetus.
it in the 3rd trimester. Are you going to give her?
No, not now. Not now, because the toxicity also needs to be considered on the mother. This valacyclovir, which is good for CMV infections, can predispose the mother towards renal failure. So we need to keep that in mind.
Okay. So now, when are you going to deliver this child? Because CMV is notorious for causing IUFD. Right. So when do you plan to deliver this baby, and what perinatal complications do you expect?
So the delivery will be based on, once again, the Doppler findings and the fetal monitoring things. When the baby is going to go into stage 2, 3, then beyond that, based on the gestation age, then we have to deliver at that point of time. And in the neonatal period, then the baby is more prone for say petechia, low platelet count, and the other problems of prematurity, and the other problems associated with IUGR itself. Specific for CMV.
My question here is very simple, Padma.
Yeah.
If I am a gynecologist, my patient has been detected CMV positive with brain changes at 30 weeks. Right?
Yeah.
We know that she has that brain calcification is there and she has an active CMV infection. You are not planning to give her antiviral at this stage. Do you want to prolong the pregnancy or you want to terminate the pregnancy? Now I want my expert to come in. Dr. Harshad.
Yes, ma'am. Tell me, please.
So I want to ask you, if there is an active CMV infection that is detected at 30 weeks, what would you, with brain changes in the baby, what suggestion would you give to the gynecologist? Terminate the pregnancy or give antiviral or continue?
No, ma'am. First of all, if only you are saying only the brain calcifications are there, or
and with IUGR, with
but what
growth
stage of IUGR?
restriction has started, it's a very means grade 1 IUGR because only the AC has gone down. Other parameters are still within normal.
Then we have to follow this case as per the guidelines, the Doppler guidelines, which Mohit Shah sir has explained us in the talk which we gave. And we have to just follow the Doppler guidelines. And if there is a ductus venosus DV reversal, then only we plan for delivery. We don't plan for
you
delivery.
You are not worried about infection? What more it's going to do to the baby?
No, ma'am, but anyways, this is 30 weeks actually. And what is the weight of the fetus, ma'am, right now? Anyways, you're going to, if you terminate now, it is going to be very catastrophic for the baby.
It is at the 20th percentile. AC is at the 8th percentile.
So exactly at 30 weeks, I don't expect more than one kilogram of this child. So it is going to be anyways. If you terminate the baby now, it's going to have anyway very catastrophic. He's going to anyways have a bad outcome at this stage of delivery.
So your suggestion is basically to continue the pregnancy.
Yes,
Dr. Padma has said
to
not to give antiviral, but to monitor and see where it takes us. Anything else on this case, or we go to the last case?
I will like to monitor with CTG also.
Agreed.
But
because
CTG...
she's crossed 30 weeks.
At CTG at 30 weeks is not very reliable.
Yes,
and,
yes, exactly.
The other things, it is almost like a pre-terminal event. CTG changes will be like a pre-terminal event.
Multimodality is always better than only Doppler.
But that is for late onset IUGR, na, Tushar? And the stage is 1. This is stage 1. This is stage 1 IUGR.
This is stage 1 IUGR at 30 weeks.
Why not giving antiviral and monitor the lady also for any adverse effects? Continuation of pregnancy and giving antiviral also.
See,
doesn't help much to the baby.
Yeah, so because the baby is already showing changes.
Already
already the baby is infected, baby is already showing changes. And when we're giving this valacyclovir, you are going to increase the toxicity on the mother. That is my thinking.
Okay.
If we can prevent the infection
we leave
being
that as an
transmitted,
open question and we will take it next time. Okay. So now we have a 28-year-old pregnant with dichorionic diamniotic twins. She is 26 weeks. One twin has appropriate growth. The other shows growth restriction, fetal weight below the 10th centile. Now the umbilical artery flow is bad. The 26 weeks, you are not really doing the MCA. The patient has uneventful pregnancy thus far, no preeclampsia. So now, how are you going to manage? One fetus is normal, the other fetus is compromised. So my question, now this is a rapid fire round. Does the type of twin pregnancy have any bearing on the management of the case?
Yes, definitely.
Dizygous twins will have a favorable outcome, better prognosis.
So what are the criteria of diagnosing FGR in twins?
Especially dizygous, we can use the same charts as singletons.
We can use
Yes,
Delphi
Dr.
consensus.
Tushar?
We can use Delphi consensus also, ma'am.
Yes. Delphi consensus can be used. What is Quintero's staging and is it relevant here?
Not relevant. That is for monozygous
For
twins.
monochorionic twins.
Yes. That is for monochorionic. It
Monochorionic.
detects TTTS.
Twin to twin transmission.
And what is a Delphi consensus and what are the criteria?
Very severe IUGR under third percentile for gestational age. One
It
criteria.
has both criteria to detect early and to detect late IUGR. In early cases before 32 weeks, there's a criteria which is either AC and EFW is less than third percentile, or umbilical artery having absent and a slip flow. Or along with two other criteria is also there, that is umbilical artery PI 95 percentile and uterine artery, I think so, more than 90 percentile.
Fifth percentile.
In early
MCA
cases.
and umbilical.
MCA less than 5 and umbilical greater than 95 percentile. In early cases.
So this is it. AC or estimated fetal weight less than third centile or umbilical artery absent and diastolic flow, or less than 10th centile with one more criteria. Uterine artery PI more than 95th or umbilical artery more than 95th. These are the Delphi consensus criteria. And this has to be applied here. So we have seen now this baby is less than 10, but it is definitely more than 3. But because it has two criteria, the umbilical artery PI is high and there is also lag less than 10%. So when we are dating the twins, which twin will decide what is the correct date? It's a dichorionic pregnancy. Which twin will decide the dating? The bigger twin.
The first one.
The larger one, ma'am.
The larger one.
No.
Which twin in DCDA twins decides the timing of delivery?
Until 32 weeks, the big twin. From 32 weeks onwards, we should consider the smaller twin also.
See, now this twin, you have to understand, is a 26-weeker. Are you going to take any decision based upon the sick twin?
No.
No, ma'am.
No.
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 As
If
Dr.
one
Shah
fetus-
said,
Yes, please.
Dr. Shah said counseling of the parents should be done about this, that they want one twin.
No, but
in
it's
good
only
health,
26 weeks.
or
You have
they
only
want,
26
the-
weeks. If one fetus is IUD, does it affect the other twin
No.
in DCDA?
No.
No, ma'am, in DCDA it will not affect.
Yes.
It's not affected.
But
So
lot of
because this is a
counseling is
DCDA,
needed.
In MCDA,
Yes, for the parents.
a lot of counseling is needed, and we would not really interfere. Even if that baby is lost, we are not really interfering. But what I ask one more question, that even in DCDA twins, does it affect the perinatal health of the baby that is born? One IUD and the other is normal, appropriate growth. Is that baby affected?
normal.
Yes, it can.
Maybe little.
There are
Yes, it
chances
can.
of infection.
No, not just infection, because the placentas are really close together and there is an effect on the complete physiological milieu of the uterus. And there can be up to 10%, there can be fetal compromise in the surviving twin as well. So now I want a take-home message from all my panelists before I really end the session.
ultrasound is a boon, and in early growth retardation, the Dopplers, the latest research helping us a lot in decreasing the perinatal mortality and morbidity. Thank you for all the research and the knowledge.
Thank you. Dr. Manu?
Yes, ma'am. Consultation with SFM people should be taken to avoid the medical legal difficulties, especially in with one IUD or in severe IUD when the growth is less than 3rd percentile.
Dr. Tushar? Dr. Sarita?
Ma'am, even we have to take.
You got muted. You got muted, ma'am. Yes.
It is a reversal of flow because we should not wait for till the changes of ductus venosus, because it will affect the neurodevelopmental part of the fetus in newborn child in 10 years due to cardiac failure. So we have to take decision for reversal flow, not for ductus venosus changes in late IUGR.
We are talking about early IUGR here.
In IUGR, the decision should be based on
early
ductus venosus.
IUGR. Yes.
Yes, ma'am.
Okay. So, Tushar? Dr. Padma?
In early IUGR, effort must be made to, to find out the cause, if there is any correctable cause and whether it can be corrected. And basically, we don't have any drugs to prevent the progression of the disease. So that needs to be explained, and the couple have to be counseled that they don't have to get worried just because an IUGR is diagnosed. A proper follow-up and a timely delivery will give them a good outcome.
Agreed. So, Tushar, you want to say something? Dr. Tushar? Take-home message? Dr. Harshad, take-home message from you?
Yes, ma'am.
Yeah, I think.
Yeah, I just want to tell ma'am that it's very important to differentiate between early and late onset IUGR, FGR, I would say, not IUGR.
Yes.
Because the management is different. That is the reason we need to differentiate. Because I have personally seen few cases in my personal practice that if the way you manage early onset IUGR is quite different the way you follow late onset FGR. In late onset FGR, the main problem is you can lose the fetus anytime if you don't follow a multi-modality approach. Whereas in early onset IUGR, anyways, the prognosis is much bad because the child is starting growth retardation from very early stage. So the achieving that required weight is difficult for early onset IUGR, but the management part becomes more predictable as compared to late onset IUGR. On ultrasound, you can predict the changes, but in late onset IUGR, you may have ultrasound finding as normal.
We are not talking of late. We are going to talk late IUGR next webinar.
Yeah, it's a comparison. So that the take-home message is you need to differentiate both and manage them differently. Thank you, ma'am.
Thank you. Dr. Tushar?
Yes, ma'am. In my view,
take-home message from you.
In my view, it is very important to monitor the fetus regularly through Doppler studies, because Doppler is a fast thing which will alert us about the onset of IUGR. Then we can plan further studies like BPP and CTG and all these things. And we have to aware the patient also regarding all these IUGR and FGR criteria. And we can discuss, we both need clinical radiological correlation with the referring gynecologist so that we can properly manage the patient and we can improve the outcome of the fetus.
Thank you. So in the end, what I would like to say is early IUGR is easy to diagnose, difficult to manage. And late IUGR is difficult to diagnose, but easier to manage. So we need to remember that differentiation and have a multimodality treatment. Now, I would like to thank all my respected panelists and experts who have been through us in this program. Dr. Harshad, our expert, Dr. Manu, Dr. Padma, Dr. Samira, Dr. Tushar, and Dr. Sarita, who have kindly been here with us in this whole program and made this program hopefully something new to learn. Thank you, Sujya, for being here, the backbone of the whole program. And thank you, Corona Remedies, for the academic support. Thank you, Aditya, for running YouTube Live. And
last but not the
thank you
least, the
so
vote
much.
appeal. Ma'am, last but not the least, the vote appeal for the committee. Yeah,
You
please
do
support
that.
ma'am, and please nominate her from your respective societies for the Food, Drug, Medical Surgical Equipment Committee. As you've seen, madam is a true academician, so she'll work towards the betterment of the Foxy. So kindly please support us, and thank you all once again.
Best wishes, Dr. Asha ji. Definite win.
Thank you. Thank you. Thank you
Thank
so
you,
much.
Asha. Thank you and
Thank
wish
you.
you
Thank you,
all
Padma,
best
for all
wishes,
your
Dr.
input.
Asha.
You are such a hardcore gynec oncologist and you have come here. I'm really happy. Thank you, dear.
Thank you. Thank you, Asha, and wish you all the best.
Thank you. Your nomination's done?
Yeah, we'll be doing it shortly.
Don't forget us, ma'am. Thank you.
Thank you. Thank you so much, Mehul.
Thank you, ma'am.
Thank